thank you so much, guys, for joining in for this emergency medicine talks. As Dr. Gina said, we're going to be talking blood and guts, basically. So we're going to look at one of the topics, one of the conditions that usually present in the emergency department. And we're just basically going to go through how does it present, what are the key things that we need to be looking out for as people working within the emergency department. And after that, how do we manage these cases? And then we'll have a question and answer session where you guys can ask your questions. Answers will vary from, I can be giving answers, Dr. Jean is here, and even I'm sure there are many other guys in this talk who can actually be able to give us answers to the questions that may arise at this time. So without much further ado, I'd like to begin. As you've heard, my name is Dr. Mutuambuvi, and let me just start this. Yeah, so basically that's what we're going to talk about. Your gut with a lot of blood inside. Okay, so what's an overview of upper GI bleeding? So upper GI bleeding refers to bleeding that occurs in the upper parts of the gastrointestinal tract, which is basically your esophagus, stomach, and the duodenum, up to what we call the fourth segment of the duodenum. And the boundary for upper GI bleeding usually anatomically it's by the ligament of Treitz. So that's what separates upper GI bleeds from lower GI bleeds. And sometimes these bleeds can be classified depending on whether they are non-variceal bleeds or they are variceal bleeds, and also due to what could have caused them to actually appear in the first place. So you can have your things that can lead to these bleedings. So you can have your erosions, your tears, infections, and things like that, which is some of the things that we're going to delve into as we continue with this presentation. So going into the etiology of upper GI bleeds, like we've said, it's mostly things that affect your esophagus, they affect your stomach, and they affect your duodenum. So we're looking at things like peptic ulcer disease, which could be both gastric and duodenal. You can have esophageal varices, which are mostly associated with liver cirrhosis, and these ones tend to bleed quite a lot. Esophageal varices are they're very tricky. They can actually bleed quite a lot. Mallory waist tear. This is for guys who have severe retching or vomiting. Mostly we see this in guys who have taken a bit too much of alcohol, like had an episode of binge drinking. And after that, they start getting these really bad episodes of vomiting. And they can actually get a Mallory waist tear, which occurs between the junction of the stomach and the esophagus. Also, these ones tend to bleed quite a lot. Then you have your other things like your gastrointestinal malignancies, your esophageal cancers, your gastric cancers can actually bleed as the tumors can actually erode blood vessels within these areas and cause bleeding. And then you have other things like vascular anomalies, basically like a Delafoy's lesion, which is an abnormally large artery in the stomach that its mucosal surface becomes eroded and can just suddenly start bleeding and can be quite severe bleeding. Other causes are things like your arteriovenous malformations. You can also have upper GI bleeding secondary to trauma. In patients who have coagulopathies, bleeding disorders mostly, they can actually present with upper GI bleeding. And also we have iatrogenic causes. Basically, these are things that we cause as doctors. Maybe when guys are doing like an endoscopy and then some trauma happens and you get bleeding coming from that. So those are also other causes, other etiologies of upper GI bleeding. Now we look at the risk factors. We can group them into several things, but I just listed them down. So we have your H. pylori infections, Helicobacter pylori infections for your peptic ulcer diseases. A major concern is basically on NSAIDs use. Many people over-the-counter medications of your diclofenacs, your ibuprofens, people take them a lot, especially people who have chronic pain. NSAID use has a big impact on upper GI bleeding. Alcohol abuse, like I said, these people can actually be drinking a lot and then they can get a Mallory waist tear after binge drinking. Advanced age, liver cirrhosis that can lead to esophageal varices. You have your coagulopathies. Smoking has also been shown to be a risk factor for upper GI bleeding. And then severe stress or trauma. And then for people who also have a prior history of GI bleeding of peptic ulcers, they are actually more prone to getting upper GI bleeds. So let's look at the epidemiology a bit. We're looking at the incidence and prevalence. Upper GI bleeding is estimated to affect approximately 50 to 150 per 1,000 population in developed countries. And then you have your mortalities. So epidemiology basically depends on your incidence and prevalence, which you said usually affects about 50 to 150 per 100,000 adults. Mortalities usually range from between 5% to 15%. With higher rates seen mostly in older patients and those with comorbidities. So you have your patient who is of advanced age, then also now is at risk. Maybe this person has a malignancy, maybe this person has your hypertension, diabetes, has coagulopathies, has liver cirrhosis. So all these things also contribute towards mortality. And then there's also a variance in the etiology. So in developed countries, peptic ulcer disease and NSAIDs usually tend to be some of the leading causes. In contrast with where we come from, like now sub-Saharan Africa, where we find that mostly it's Helicobacter pylori infections in mostly Asia and Africa that tend to cause a bit of the majority of the cases of upper GI bleeding. And this one, as you see, like when you talk about sub-Saharan Africa and you look at the epidemiology of upper GI bleeding, some of the things that tend to cause mortality or cause a bigger severity of upper GI bleeding in sub-Saharan Africa is due to factors such as social economic factors. So this includes like things like access to healthcare. And then you have infectious diseases where we are looking at things like schistosomiasis, amoebiasis, which can also cause upper GI bleeding. And then you have your health infrastructure limitations. So, like I said, high prevalence of infectious diseases, you have your gastrointestinal infections, things like schistosomiasis, amoebiasis, your H. pylori also falls in there. Liver diseases and portal hypertension, these tend to be quite common in sub-Saharan Africa. Challenges in diagnosis and access to care. Not many facilities or hospitals actually have gastroenterologists in their midst or have even an endoscopy unit within their system. So it becomes a challenge in terms of access to care. Malnutrition and anemia have also been shown to be also a major factor in terms of comorbidities, especially for upper GI bleeding. And also the fact that we have limited data and surveillance evidences from many of the Ministry of Health organizations from sub-Saharan Africa. Many cases of upper GI bleeding, number one, maybe may not get reported, may not be captured in the hospital records, it's not data that is easily available for us to actually have a look at and give like proper prevalence, incidence and prevalence data in regards to upper GI bleeding for in this particular aspect of upper GI bleeding. Now, after looking at those ones, one of the things that we need to actually understand more and actually look into is mostly the pathophysiology. So when you look at the pathophysio of upper GI bleeding, we're looking at the upper GI tract, which is lined with a protective mucosal barrier, which is composed of mucus, bicarbonate, and those tight junctions between the epithelial cells. Now, various factors can disrupt this barrier. Now, remember, underneath this barrier is where now you find your blood vessels, which are beneath the mucosa. So at any point when this barrier is disrupted, there's now the increased risk that the blood vessels can actually be affected, that even the blood vessel cannot begin to wear out and then begin to tear, and that's where you begin to get your bleeding from. Now, there's out of all the with all the etiologies that are happening, there's a common pathophysiological pathway that we all follow. So when you begin on this, we look at now once the mucosal barrier is disrupted, the blood vessels in submucosa become exposed to the acidic gastric environment. Remember, your upper GI is quite acidic. This is just the normal physiology of it. So now, this exposure, like we said, can occur due to various things. So one, you can have your ulcerations, which we're looking at things like peptic ulcer disease, your H. pylori infections, which are number one causes. You're looking at your use of NSAIDs, non-steroidal anti-inflammatory drugs. And you're also looking at other things that could cause erosion, these things can cause erosion of the mucosa and the submucosa, leading to exposure of the vessels, sorry. So when you look at varices, varices tend to now cause your dilated veins, such as esophageal varices. They develop due to increased pressure in the portal venous system. And these varices, they usually, once these veins dilate, they become very fragile and they're very prone to rupture. Things like tears, Mallory waist tear, or other mucosal tears expose the underlying blood vessels. And then tumors, gastric malignancies, they actually invade the mucosa and the submucosa, and then now they disrupt the blood vessels, and this can lead to the bleeding. So the first part of it is that this exposure of the blood vessels, this is through the interruption of the mucosal barrier that's meant to protect them. Now, once that happens, now you get your initiation of bleeding. So once the blood vessel is exposed, bleeding can occur. Now, the factors which contribute to this bleeding are things that include your gastric acid. So if your the acidic environment of your stomach can actually directly damage the blood vessel walls. And then you have things like coagulation factors. A disruption in the mucosa can also lead to a disruption in the balance of coagulation profiles and your anticoagulant factors within the blood vessel. That's making bleeding more likely. Then you have things like mechanical factors where varices are under increased pressure due to the portal hypertension, and making them more likely to rupture with very minimal trauma. Then you have your tumor invasion. So these tumors directly invade and erode the blood vessels, leading to bleeding. So first you have your mucosal area, your mucosa is damaged and it's exposed. Then now the bleeding begins through these factors that we have discussed. Now, so what is the importance of understanding the pathophysio? Why do we need to know the pathophysio? The reason you need to know the pathophysio is because one, you need to know timely recognition. So once you understand the common pathway, which is those things that we have discussed, it's easy for you to recognize the signs and symptoms of upper GI bleeding. And then it can also help you to do targeted management. For example, if you're thinking this person has H. pylori, then you can obviously decide to put this person on anti-ulcer medications. Or for varices, you can decide to immediately start calling your gastro team and telling them, yeah, you know what, we need to do an endoscopy band ligation for varices. And then also, these things also help in prevention of recurrences. Once you understand the underlying cause, you're able now to put in mitigation measures that will help you to prevent recurrence of bleeding episodes in this particular patient. Now, once you've understood the pathophys, now we can come now to our clinical presentation on how these patients present. Now, the clinical manifestations of upper GI bleeding depend on the severity and the rate of bleeding. So the common signs and symptoms. So now the common things that your patient will present with to the emergency department include, number one is hematemesis. Now, hematemesis indicates this active bleeding from the upper GI tract. And when you talk about hematemesis, you're talking about actual, this can be two things. One, this patient can actually be vomiting fresh blood. Or number two, they'll be vomiting what we call coffee ground appearance blood. Now, the difference between the two is this. Your patient can have an upper GI bleeding, and this blood, first of all, taking into consideration things like the anatomy of the body. So once this upper GI bleeding starts, it's mostly going to land into the stomach. In the stomach, what do you have there? You have your gastric acids. So your gastric acids begin to digest this blood. So when this patient is vomiting, so they're vomiting something that looks like coffee ground. Coffee ground, that's kind of brownish-like substance. And I know sometimes there are people who say coffee ground and they really don't understand what coffee ground looks like. So once you're done with this, kindly go buy a sachet of coffee, just put it in water, mix it and see how it looks like. Kind of looks something like that. And sometimes this patient can actually even vomit up clots and actually can vomit up actual fresh blood, depending on how severe the rate of bleeding is. Now, you look at Melina stools. Melina stools is basically also as part of the digested blood in the GI tract, and this can actually be seen in the stool. So what we call Melina stool. So you can actually see that the stool that this person is producing actually has digested blood. So the stool looks very dark and tar-like and very, and people are saying it has a really interesting smell. Yeah. Then you have hematochezia. So hematochezia is bright red blood in stool. And this one can indicate two things. One, it can indicate a brisk bleed, and it's most often from the upper GI tract. What this means is, let's say your patient has a varice, esophageal varices, and then that vessel just ruptures, and just a huge amount of blood is just dumped into your GI system. So now some of that blood can actually be able to make its way through the entire GI system and come out through the rectal area while still looking like fresh blood. And this actually indicates that, yeah, one, you've had a very brisk bleeding, and it's actually quite a big amount of blood for you to actually get fresh blood that's coming out through your rectum, basically parectal bleeding. The other things that your patient might actually present with are things like now abdominal pain. They'll complain of epigastric pain, upper abdominal pain, may be due to the underlying cause, things like your peptic ulcers. So peptic ulcers, we know, tend to give you epigastric pain, so that could be one of the things. Now, also depending on how badly this patient is bleeding or how severe the bleeding is, your patient can come in when they are weak, they have fatigue, sometimes they can have pallor, but remember by the time you get in pallor, it means your patient has been having a chronic bleed. So it could be like chronic blood loss that has been just going on slowly by slowly, building up, and now this patient is actually presenting with signs of pallor, and then fatigue and weakness as well. Now, the major thing that brings these patients to emergency department, or where in the emergency department we have to now, be up on our feet and running, is when you're thinking about whether this patient is getting orthostatic hypotension or whether this patient is getting into hemorrhagic shock. Because remember, your patient is actually losing blood. So if they're losing blood, they will now begin to show signs of volume depletion, which are basically the signs of shock. So you'll have your tachycardia, your hypotension, and all these things when you're looking at your vital signs. So those are some of the clinical presentations that your patients will basically come with. And one thing I can say, like now from actual practical experience of actually having dealt with a few patients who are coming up at bleeding, you get it from like the two ends of the scope. So from one end, you can find this patient who will come in They will have the pallor, they will have the fatigue, the weakness, and they will tell you, yesterday I vomited, and I vomited something that looked like brownish substance and things like that. So this patient is actually weak, but they're still able coherently enough to tell you that, yeah, yesterday I vomited this amount, this thing that looks like it's black and it's okay, black brownish like that, but it was only like one episode and then it stopped. And from then I've just been feeling weak. And when you do your vital signs for this patient, you find that the vital signs are within the normal values. So you feel like you still have time now to do like proper investigations and maybe even plan for an endoscopy for this patient. And then on the extreme end, you have these patients who come in and they've been brought in by their relatives, and the relatives just tell you this person just started vomiting like maybe an hour or 2 hours back, and they've been vomiting up like really dark, black brownish substances, and it's been ongoing. And even when you're there with that patient, you actually see them actually vomiting. And that's when right now you're starting to say, okay, this guy might be having actually a major GI bleed, and we need to intervene as quickly as possible. And that's when now we are actually going to, when you're looking at now, how do you work around your diagnostic workup before you begin your management of your patient? So when you're looking at your diagnosis and you're trying to figure out what's actually going on with this patient, there's some things that you need to do. So number one, getting your history. So you need to know when was the onset, when was the onset of this upper GI bleeding? Was this patient vomiting? How has the history been prior to the time this patient has come to your facility? What is the duration? Has it been a day, 2 days, a week? Depending, it could be. Then what is the severity? Is this person is he vomiting up blood like every hour? It's just vomiting and vomiting and vomiting. So that one gives you an indication of how severe the illness is. And also when you're looking at your physical examination, like we've said, your vital signs are going to be a key thing. So you're looking for signs of hemodynamic instability. You're looking for tachycardia. You're looking for hypotension. You're looking for orthostatic changes. And these ones may indicate a significant blood loss. So at times, you also need to remember that sometimes there are patients who may be hemodynamically unstable, especially when it's just starting out, but they may not present with tachycardia, but they might have a bit of hypotension. So those are some of the things that you need to actually look into when you're assessing your patient in terms of physical evaluation. Now, as part of the evaluation, there are certain scoring systems that have actually been developed to help us to understand how we're going to manage a patient with an upper GI bleed. Some of these things may, depending on how severe your patient, what's the severity of your patient, you may not have maybe time to do the scoring system, but it can come in to help at some point. Now, during the research for this particular presentation, I found there were actually 5 scoring systems that are available. We have the Rockall score, which now this one incorporates both clinical and endoscopic findings. So this one technically kind of rules out its use in the emergency department because you may not be able to do an endoscopy when you're in the emergency department and your patient comes in with an upper GI bleed. AIM65 score, same thing. It's a risk stratification tool that predicts inpatient mortality. So this basically applies more when your patient has already been admitted, so that we see whether is this patient going to make it, what are the chances this patient is actually going to make it out alive from our facility. Then the CEDAR-Sinai Medical Center Predictive Index. Now this one just helps to show, are we going to need surgical intervention for this patient who has non-variceal upper GI bleeding? Now your patient who has pelvic ulcer disease or PUD that has actually eroded into, let's say, the duodenal artery or something like that. Now you're looking at what point do we need to do like surgical intervention for this patient? Now, the Rockall score also has a pre-endoscopic score, which is just a modified Rockall score, and it excludes now the endoscopic findings and can be used to assess the risk of adverse outcomes before endoscopy. But all these systems are available, but the one that has been shown to be quite useful, especially in the emergency department, is the one we call the Glasgow-Blatchford score. Now, the Glasgow-Blatchford score is a pre-endoscopic risk stratification tool for identifying low risk of adverse outcomes. And it can also help us to determine which patient can we allow to go home, and then we do outpatient management, and which patients do we actually need to admit into the facility and actually sort them from the facility. Now, it has several components which include the age of your patient, your HB levels, your vital signs, your BUN, your blood urea nitrogen, and I'll discuss that a bit as I'm going through the score. And then you have other clinical parameters. Now, a low GBS score of 0 to 1 indicates low risk of adverse outcomes and may guide decisions regarding the need for urgent endoscopy and hospital admission. So if your patient has a low score of 0 to 1, these are patients we actually saying that you may be able to actually treat them as outpatient. You can give them some medication, send them home, have them book like gastro clinic, and give them like a talk on what are the danger signs or what they need to look into in case they find that what are the danger signs that they need to look out for, so that in case they start having another rebleed or it becomes severe, they need to come back to the facility as quickly as possible. Now, like I said, the score has some features. I don't know how clear this is, but I'm hoping everyone is able to see it. So these are some of the things that we are using the score specifically. So first thing is first, you're looking at your blood urea nitrogen. Now I know in the African setup, we don't do BUN. We usually do urea levels. So most facilities are able to do a urea, electrolyte, and creatinine. Now there's actually a conversion. There's a conversion that you can do. Once you do your UECs for your patient and you have your urea levels, there's a way you can actually change them into a BUN level. And this one just for additional knowledge, but this is info that you can actually just find online in the various calculators, medical calculators that are there. Basically, what they say is that once you have your urea levels, and you know our urea levels are usually in millimoles per liter. So if you want to convert your urea levels into the BUN, what you call the BUN in milligrams per deciliter, divide it by 0.357. But that's something that you can find online. So you can do your urea levels, convert them, bring it to this table, and then get your score for your patient. Then we also check our hemoglobin levels. It also has aspects of the systolic blood pressure, has aspects of the heart rate, and then gives a score for if your patient has melena stool, if your patient has had syncope, if your patient is known to have hepatic disease, and your patient is known to have cardiac failure. But like I said, it looks like it has a lot of things on the Glasgow-Blatchford score. But when you're looking at your patient who's coming with a major GI bleed, you may not have time to actually do all this. So what are the key tenets in terms of management of a patient who comes in with an upper GI bleed? So one of the things as we continue to go forward is that we have the emergency care algorithms. This is the 2023 version. And the good thing about it is that it actually has an algorithm of how do we go about dealing with the patient who presents with an upper GI bleed. So if you, I'll actually just go to that and we can have a look at what is the algorithm on upper GI bleed. So upper GI bleeding. So this is the algorithm that we use in the emergency department. And we're just looking at the key tenets of it. So you have your upper GI bleeding and with the various presentations, but most cases present in one or more of the four following ways. So you have your melena stool, which is about 69%. This is a passage of dark and pitchy stool stained with blood pigments or with altered blood. And you have your hematemesis, which usually is about 30% of the presentation, especially for and indicates an upper GI bleed. You have your coffee ground emesis, and you also have your hematochezia. Now, once you have all this, as you see, the key things in the emergency department is that you're looking at how quickly can I save my patient? We're looking at what are the key things that I'm going to do immediately that can actually save this patient in terms actually be able to stabilize the patient. So when you look at these things, so there are two ways you can actually see this patient. So one, you'll classify your patient as either one, your patient is in shock with hypotensive shock, or your patient is hypotensive, and number two, your patient who is not in shock. So let's start with obviously the main one, your patient who is in shock. So what are the key things? Obviously, we always start with your ABCs. So you check your airways, breathing, circulation. We'll discuss a bit more of this as we continue into the discussion. And then as we go now, key point by key point to see what we can do in a particular setting. Then check your vital signs. Start your oxygen if your patient has a SpO2 of less than 94%. Then you need to establish two large bore IV cannulas. This is very, very crucial because remember, your patient is losing a lot of blood. You will need to replace some of that. You'll need to give some fluid. You'll need to even transfuse some blood. So you need to have two large bore IV cannulas running immediately at that time. Then give rapid fluid boluses. You can give your 20 ml per kg of Ringer's lactate or Hartmann's solution, and you can repeat if necessary. Start your blood transfusion only if your HB is less than 7 grams per deciliter. And then your usual lab works. Do your full blood count, check for any signs of an infection. Do your urine electrolytes, your liver function tests. You can do a venous blood gas, and then get your coagulation screen. And then cross-match 6 units of packed red cells. We'll also discuss about the components of blood and how we're going to give it. Then perform a brief targeted history. This includes a physical examinations, including a rectal examination. Then insert an NG tube only if your patient is intubated or your patient has recurrent vomiting which is uncontrolled by antiemetics. And in most instances, you'll find if your patient is having recurrent vomiting and it's in large volumes and it's not controlled by antiemetics, you will have to secure the patient's airway. So by that point, you'll actually have to think about intubating your patient. And then at that point, once you intubate, you can put your NG tube, but we will discuss this as well as we continue with the presentation. Now, looking at your other patient who is not in shock, still monitor your patient's airway breathing and saturation. You'll need to intubate patient if airway is at risk from massive hematemesis, same as the person who is in shock. Then check your vitals, start your oxygen, establish your large bore IV cannulas, give your IV fluids, your Ringer's lactate, and then transfuse only if your HB is less than 7, and then do the basic blood works that we've discussed about, and still perform a brief targeted history and physical examination, including a rectal examination. So that one is actually very important. Now, some medications that can be given, we usually say that you can give your IV omeprazole, 80 milligram bolus, followed by an 8 milligram per hour, 8 milligrams per hour for 72 hours, or you can use pantoprazole in case your patient is on clopidogrel. The reason for that is that omeprazole and omeprazole tends to enhance the clopidogrel antiplatelet effect. So that may be, in the long run, may be detrimental to your patient because you want your patient to be able to actually form platelets so that they can be able to clot, so that they don't continue bleeding. Monitor your vital signs every 15 minutes, correct your hypotension, and then monitor your urine output with an aim of 0.5 mils per kg per hour, which is usually the standard. Most veterinarians say 0.5 to 1 mil per kg per hour. And then consult your gastro team, and then admit your patient to your HDU or to your ICU. That is a basic protocol that we use in the emergency department. Now, if we go back, if you allow me to go back to the presentation, initial management of your patient who comes in and they're having upper GI bleeding. So one thing is you need to get oxygen, like we said, if your patient has a SpO2 of less than 94%, but sometimes I tend to think that it's good just to put your patient on oxygen as you're doing these things, and now you can be able to titrate down on your oxygen as you continue doing your other interventions. Then attach your patient to a monitor. That is also very important because this helps you to maintain a proper check on your patient in terms of their vital signs. And then get your IV access. Get IV access. So we said we always have to check your airway, breathing, and circulation, your ABCs. So now if we look at airway and we just delve into this a bit, for your patient who's having massive hematemesis, you have to take that airway. Because if your patient continues having massive vomiting, they have an increased chance of getting aspiration pneumonia. And then now that just complicates everything for you even more. So most of the time you'll find that you need to secure your patient's airway. Now, some of the things that you need to consider when you're doing your rapid sequence intubation is to think about the medications that you're going to be using. One of the medications that has been, especially for your sedatives, that has been recommended is ketamine. And the reason for that is ketamine tends to, has been shown to have a positive effect in terms of blood pressure. It actually helps to maintain your blood pressure, and sometimes it can actually even help increase your blood pressure. So that's why it's one of the preferred sedative agents. And then you can use your SUX or your atracurium for now as your paralytic agents. The other thing is that when you're actually doing your rapid sequence intubation, you need to ensure that you have a suction machine and a suction tube that's actually working. Because remember, this patient is actually having massive volumes of the patient is vomiting up a lot of blood. So you need to have suction so that once you're paralyzed, you're sedated and you've paralyzed your patient, you want to quickly be able to suction your airway and quickly intubate your patient so that you don't risk the patient having, in that state of paralysis, so that you don't have a lot of, waste a lot of time trying to visualize your vocal cords. And there's a lot of blood that's within that area, so you're not able to see. So you need to have very good suction. Very good suction. So intubate your patient. And once you've intubated your patient, one of the things that you can do at that point is you can actually pass an IV. Now, remember, sometimes upper GI bleeding there are other things that can mimic upper GI bleeding. Someone can come and say that I vomited up something that's blackish, brownish, coffee ground, and you'll start thinking, oh, this guy actually has an upper GI bleed. But maybe this guy might be having a posterior epistaxis, and that blood that is actually coming from the posterior part just goes into his esophagus, because he's actually swallowing that blood, and it goes into the stomach, and then when he vomits, that's what he vomits out. So you maybe think it could be upper GI bleeding, but it could be something just like it could be epistaxis. So one of the things when you're doing your intubation, it can also help you to visualize where the blood is actually coming from. And the concept of actually even adding an NG tube to that, the NG tube as it goes into the stomach will also be able to show you that, yeah, this bleeding is definitely coming from the stomach, depending on what is actually going to be coming out of that NG tube. So once your patient is sedated, paralyzed, and you've intubated them, insert an NG tube. That will be the next thing that you will do. We know inserting an NG tube on a patient who is awake is a very uncomfortable procedure. But so now the good thing is that here, for this particular patient, you've actually intubated them and they are paralyzed, they're sedated, you're able to pass your NG tube very easily. So number two, you need to manage your breathing. So check your respiratory rate, assess the risk for aspiration pneumonia. Like I said, if your patient has massive GI bleeding, you may need just to actually take that airway and actually just secure the airway. And now you'll be able to now see how you're going to manage your patient. Circulation, check your patient for your BPs, your pulse rate signs, your BP and your pulse rate, and then look for signs of hemorrhagic shock, your tachycardia, your hypotension, all these things. And then establish adequate IV access. Here we're talking about 2 large bore cannulas. And here we're talking about, I know in the algorithm it says gauge 14 to 18, but the bigger the gauge, the better. So if you're able to pass a gauge 18, which is the green cannula, or anything above green, your gray, white, orange, any of those, if you're able to pass those ones, excellent. If not, maybe we can accept a gauge 16 if it's an adult. That's the pink cannula. So that one, sorry, a gauge 20, that's a pink cannula, which can actually also be able to help. But if you're able to access a green cannula and you can put 2 of them, even better. The basic lab works that we said, your full hemogram, your USAs, your LFTs, your coagulation profile. You also need to do your grouping and your cross-match because you may get to a point where you need to give your patient blood. So you need to get a sample for your grouping and cross-match. Then fluid resource, like we said, you do your 20 mils per kg as a bolus, and you can repeat if you feel the need to. Now, like we said, for your transfusion, you transfuse your patient has a HB of 7 grams per deciliter less. But sometimes if your patient is still having an active bleed and their HB is 8 grams, is less than 8, is 8 to 8 and below grams per deciliter, you can also consider transfusion. Now, also remember that sometimes if you're having massive transfusion, you may actually just have to give blood regardless of the HB. If your patient is actually vomiting up bright red blood, as you guys should see, this is actually copious amounts of blood, and then your patient is actually going into shock. You can give your IV fluids, yes, but remember, one of the things that actually happens in emergency departments, or actually is supposed to happen in emergency departments, is if your patient is losing blood, give them blood. You can give them fluids for the initial part, but at the end of the day, you need to give them blood. You need to give them blood. So that's the thing. And when you're talking about the aspects of massive transfusion protocol, like for your patient, if you realize your patient is actually like really, really badly off, they have really lost a lot of blood, and now you need to give your what you call your massive transfusion protocol. There are facilities that have these particular protocols, and basically what we say about massive transfusion protocol is what we call the 1:1:1 ratio. Now, what it means is this. As you saw in the algorithm, it said you prepare 6 units of packed red blood cells. That is the same concept. So the 6 units of packed red blood cells are considered as the first one in the 1:1:1 ratio. Then the second one is for fresh frozen plasma. And that one also, it means 6 units of FFPs. And then the last one, which is platelets, here we're saying it's only just 1, or what you call pooled platelets, 1 unit of pooled platelets. So that's your basic massive transfusion protocol of 1:1:1. I know chances of getting that in the facilities that we work with. There are some facilities that may actually have access to this. Others, it's actually very tricky. You may be able maybe just to get like a unit of blood or 2. But when now you're talking about FFPs, you're talking about platelets, it becomes a bit out of the line, yeah? So that's the other thing you can be thinking about, put a massive transfusion protocol. And then you need to do your input and output charting. So you may need to catheterize your patient, because like we said, you need your patient to produce at least 0.5 to 1 mil per kg per hour of urine. So you need to be able to monitor this. The only way you can monitor is establishing a urinary catheter for your patient so that you can actually be able to monitor. And as you're charting, you're looking at what are we giving the patient, what are they bringing out. Now remember, this is just the initial management of your patient. You're just trying to stabilize them so that now you can figure out what else is going on with this patient and how are we going to manage the outcome, this upper GI bleeding that this patient has. So the next thing that we're going to give is medications. Now, antibiotics usually give ceftriaxone like 1 gram 12 hourly. Now, there are some studies that have been done that have shown that antibiotics actually have an impact on mortality in upper GI bleeding. During the research I was doing for this, I found some of the articles, and they were actually saying that most of the times when you find a patient with an upper GI bleed, especially if it's a esophageal varice, if it's PUD that has caused the rupture, or one of those things, there's usually a translocation of the gut normal flora can be sent out into the rest of the body. So your patient can actually become septic. Now, antibiotics have actually been shown to have an impact on mortality in patients of upper GI bleed. Now, the other thing that we usually give is your PPIs, your omeprazole or esomeprazole, 80 milligrams start, and then after that, you can actually do an infusion of the same if you're able to do that in your facility. Now, there's this drug called octreotide, which is a sandostatin. Now, this one it's only given if you're suspecting that your patient has esophageal varices. And how do you tell? You can tell from the history of the patient is giving you. If your patient has a history of liver disease, cirrhosis, he's an alcoholic, he drinks a lot. So those are some of the things I can tell you. Yeah, this patient may actually be dealing with varices, and also looking at the amount of blood that this patient is actually vomiting up, or the amount of blood that this patient is losing. So you can decide to give your octreotide, which is we give it at 50 micrograms IV as a start dose, and then followed by an infusion of 25 to 50 micrograms per hour for at least 2 to 5 days. Then for your patients who have liver disease, you may consider giving vitamin K, because now remember, if your patient has liver disease, it means they could be having clotting disorders. So vitamin K could actually help you with that. And that's why we actually do your liver function test, so that you can see how your liver is actually working. Now, coming to tranexamic acid. Tranexamic acid was actually one of the things I looked into, and Dr. Gina told me that she was going to ask me this question. And I did a bit more preparing because I knew it was going to be an interesting discussion. So we're going to do a bit more discussion in terms of the use of tranexamic acid in upper GI bleeding. And I'll just let you know about some of the studies that I went through that were giving. Some were saying, yes, you can use it, does have benefit. Others were saying, not really. There's no benefit on mortality. There's no benefit in terms of reducing the amount of blood that the patients are passing out. So we'll actually go through that. And we'll discuss that as we continue with the slide. Now, this is what we call a Sangsten-Blakemore tube. Now, if your patient, let's say your patient is having massive upper GI bleeding, and you have done everything. You have secured the airway, you have passed your NG tube, you're giving your blood, you're giving your omeprazole. Basically, you've done every step on the way that we have talked about, but your patient is still bleeding. Now, I know, okay, maybe I'll talk personally. I know I've never seen this in real life, but it's one of the things that you read about in your textbooks when you learn about management of upper GI bleed. So this is a Blakemore tube that is actually used for tamponade in the abdomen. Now remember, the interesting thing about upper GI bleeding is it's one of the things where we know your patient is losing blood, but you can't quantify the amount of blood that they're losing, because there's what they're vomiting and there's what is being retained in the body. So you can't really quantify how much blood that they're losing. Number two, especially in the trauma setup, the way we stop bleeding is through pressure. So we usually say, hey, put as much pressure as you can on that thing until that bleeding stops. Unfortunately, an upper GI bleed, it's internal. So in a way of trying to do that, like put pressure or tamponade, that's where the Sangsten-Blakemore tube comes in. Now, for those of you who have access, I can ask you to just check YouTube. I'm sure you can find some videos of how this thing is used. But one of the resources I saw that has an excellent video on the use of the Blakemore tube on how to insert it into a patient who's having an upper GI bleed. For those guys who have access to EMWrap, the emergency medicine wrap, what is it? The app, yes, the app. It has very nice videos on how to utilize the Blakemore tube. But like I've said, personally, I've never seen this. I don't know, maybe when we'll be having the discussion, anyone in the chats, or anyone who has ever actually seen the tube, not even just used it, but has actually seen it. So cool, you can actually tell us about it, and we can just have a small discussion around it. But this is one of the other things that you can do as you're calling your gastro, as you're planning for transferring this patient from where they are to a place where they can actually be assisted. So that's what we call a Sangsten-Blakemore tube. So I just thought I should show an image. So it's just like, consider like putting pressure or putting like a very big balloon into the stomach. And the good thing about it is that it actually covers the stomach and covers the esophagus as well. So it just provides that pressure and prevents the bleeding stops the bleeding from continuing. Yeah. Then you're looking at definitive management. You need to consult your gastro for emergency endoscopy. And sometimes this can be done within 24 hours, depending on how well you resuscitate your patient. The other thing is that if the bleeding is really, really bad, you may need to consider now calling in your surgeons, your general surgeons, or the guys who are now specialized in gastrosurgery, because you might actually, this patient may need to actually go and have a laparotomy done. Now, speaking of that, as you can see, the initial management of this patient is, there are things that we can actually do in the department, and there are those things that we can't do. So as you're managing this patient who has upper GI bleeding, one of the key things that needs to be running in your mind is that, how far can I take it to this patient in my facility, and depending on the resources I have in my facility. If, number one, I'm in a facility where we do not have a gastroenterologist, or you might have a gastro, but there's no endoscopy machine, and you're trying to think, okay, how are we going to do this? You need to be already starting to think about, how quickly am I going to just stabilize this patient and move that patient to a facility where they can actually get these services done. So that, as you're managing this patient, that also needs to be at the back of your mind. It needs to be running so that you know, okay, yeah, I'm doing the best that I can, but at a particular point, if I'm able maybe to get to a point where I'm giving this patient 1 unit of blood, I need to have already called a referral facility where I know they probably have a gastro, they probably have endoscopy services, and I'm already planning on how we're going to transfer this patient out of a facility onto the next one. Now, like I said, some of the articles I found in terms of the use of tranexamic acid in upper GI bleeding are these ones. I know this presentation will be available, so when you guys go back to the presentation and you're watching it later, hopefully you can actually go and Google some of these trials and see what they talk about in regards to the use of tranexamic acid in upper GI bleeding, and some of them even include lower GI bleeding. Now, my take on tranexamic acid is that, from what I've read from all these things, that the key point I got from all this from these studies was that we are yet to have a proper study that has been done on a good subset of patients that can actually give us credible data. Everyone here has a different opinion. Like the first one by the first that's written that tranexamic acid for GI bleeding, a systemic review and meta-analysis. That one, actually, the conclusion of that particular research was that, yes, tranexamic acid, especially given within the first hour of this patient arriving, has actually been shown to have benefits towards better care of this patient in terms of reducing the bleeding. And number two, they were saying it also has an effect on reducing mortality. However, the HALT IT trial, which was published in the Lancet journal in 2020, has an opposite opinion. It says that there's basically no evidence for tranexamic acid in upper GI bleeding. And one of the other studies that I saw that was actually interesting was, now they were debating on, how do you administer this tranexamic acid to this patient who has upper GI bleeding? So one was saying, you can do IV tranexamic acid, which they were saying still doesn't have the desired effect that they would want, especially for patients with an upper GI bleed. Number two was now using an NG tube to actually, as the patient has an NG tube, now you just give like they were saying about 2 grams of tranexamic acid through the NG tube and see whether it has an effect. Also, that one had not the desired effect. They couldn't really quantify the effect of that particular medication. Then the third aspect about it, they were saying, what if we actually give this tranexamic acid as an oral, as actually give the patient to swallow? Because now the idea is that once the patient is swallowing, so it's actually passing through the esophagus, lining the esophagus all the way down to wherever the bleed is, and then seeing whether it will actually have a local effect in terms of reducing the bleeding for this patient. Basically, like what we do for epistaxis, when you get like that swab and then you pour some tranexamic acid, roll it and stick it into the nose, and then it helps to prevent the bleeding. That was a similar concept. So there was this whole debate about, first of all, how do we administer this tranexamic acid for the patient? Number two, what are the desired effects? And number three, which is actually the key thing, does it have an impact in regards to reducing mortality rates for these particular patients? So I'll urge you guys, just have a look at these studies if you can, get resources. We can discuss this at the end of this presentation, and then we just see, we can go back and forth on it and see whether it's actually available, because I know there are very good tranexamic studies that have been done, especially for trauma patients. Your patients your RTA victims, your guys who have been cut, bleeding, those ones, TXA has been shown to have very wonderful effects. But now what happens when now this bleeding is internal? That's where the question comes in. And that is the end of my presentation. I hope I have not skipped anything. Looking forward to the questions that you guys are going to ask. As you can see, please don't ask any questions. Let this be the end. It's a Thursday. Okay, well, see Friday, but it's a Thursday, so it's all good. But thank you so much for listening in. I'm now open to any questions. Dr. Jean, I think we'll be able to moderate this, and then we can just move and see what else to discuss. Thank you so much.
Thank you, Dr. Mbuvi. That was quite robust. I think you touched on a lot of things. Thank you so much. Let's give him his Makofi. Thank you so much. As you catch your breath, there are some Q&A. The first one that I think is a good one. In the places where you talked about octreotide, is it possible to use telepressin instead?
To use what?
Telepressin.
Oh, telepressin. Okay, yeah, sure. All right. Next question.
So then the next question is regarding the massive transfusion protocol. Maybe you can go over it again in a bit more detail, slower, so that people can just have a look at that.
Okay.
So far, that's the second question. Maybe you can take those two first.
Okay. So the first one, telepressin, I'm not so sure about that, so I will defer that one. We can put it as a research point so that guys can actually we can discuss about it. So that one I'm not so sure. So I will not want to give an answer that is incorrect. So yeah, but anyone, people in the comments, I'm sure the guys who have experience with this thing, so you can actually, yeah, you can give us some insight on that. Now, in regards to the massive transfusion protocol, MTP basically, what it is that for sometimes in the emergency department, you do find you get your patients who have come in with really, really bad trauma, and they have lost a lot of blood. Basically, your patients they're basically exsanguinating, and you need to replace quite a large volume. You need to replace that blood volume with another. You need to replace that blood volume. One of the things is you can give your IV fluids, but those will just help to keep your what is it called? Just keeping your vitals slightly better. But remember, like we said, if your patient is losing blood, you need to give them blood. Now, the reason why we think about the massive transfusion protocol is that when you realize that your patient is in a really bad state and you need to give a big quantity of blood, there are certain ratios that you have to give your blood, because you just can't give your packed red cells only. If giving like more than 2 or 3 units of your packed red cells, you need to also start considering that you need to give your clotting factors, which is your FFPs. And also, remember, your packed red cells do not have platelets, so you also have to give your platelets. Now, the ratio itself, I think it just came from many studies. And one of the things about emergency care, the studies that have been done have shown that if you're giving about 6 units of packed red blood cells, you need to do it in that ratio of 1:1:1, where you're giving your 6 units of packed red blood cells. So for those ones, remember, your packed red blood cells, you're increasing your red cell volume. Then now you also need to consider your coagulation factors, because remember, as you're giving your platelets, as you're giving your red blood cells, your patient is still bleeding. They have lost their coagulation factors, a lot of them. So you need to replace that. So as you're giving your red blood cells, you're giving your FFPs as well. So, and they say if you're giving 6 units of whole blood, 6 units of packed red blood cells, you're giving as well with 6 units of your FFPs. And then now, the last thing which you need now, which helps you now that clotting mechanism and everything, is your platelets. So remember, now getting your pooled platelets, so you just need 1 unit of pooled platelets so that you can be able to give that full ratio. Like I said, it is a protocol. There are hospitals that actually have these protocols, but they're protocols that need to they're developed in places where you can actually have access to your blood transfusion unit. You have discussed with your team in the blood transfusion unit, and they know that once we say we are doing a massive transfusion protocol, they understand exactly what it means, and they understand the kind of danger that the patient is in and why they need such a large volume of blood to be transfused on that patient at that particular time. So that's what we talk about when you're discussing about massive transfusion protocol. So those ones, like I said, basically for your patients who are either exsanguinating, as in they have lost a lot of blood, and you need to replace all that blood. Sometimes you can even end up replacing the patient's entire blood volume through a massive transfusion protocol. So think about it in that sense. Yeah.
Okay, great. I'll take the telepressin question. Yes,
awesome.
you can use it if you have it. There was actually a systematic review done in 2003 that recommended it as first line for variceal bleeds, because it essentially reduces your portal venous pressures by reducing blood flow there. So yeah, it kind of works the same way as octreotide. So you give either or whatever you have. So that's okay. The next question we have in our Q&A panel, we have, can a hiatal hernia cause bleeding?
Hiatal hernia. Not in the literature that I came across in terms of the causes. Not so sure about that one as well.
Yeah,
but
I agree.
it didn't come across any of that. But maybe if you have an answer.
No, I agree. Unless like there's other confounding things, but a hiatal hernia itself doesn't necessarily cause bleeding. Okay.
Mm-hmm.
So the next question, what is the difference between upper versus lower GI bleed in terms of symptoms?
Okay. So the difference between upper and lower GI, like I said, the anatomical cutoff is what we call the ligament of Treitz, which tends to pass through the fourth part of the duodenum. Now, any bleeding that occurs above that part is considered upper GI bleeding. Anything below that, lower GI bleeding. Now, what the difference between the two is that once you have in lower GI bleeding, okay, basically it will be parectal bleeding. So now it comes out as what we call melena stool. So basically it's already partly digested, it's been mixed in with food and fecal matter. So when it comes out, you have this patient who has this what we call tarry-like stool. By tar we mean, you know that black thing that they use when they are carpeting roads is something that's black. It looks like that's tar. Now they tend to get stool that looks like that. Now, from what I got was that lower GI bleeding in terms of symptomatology. Now, these are the patients who will tend to present with things like pallor, because you find for them that bleeding usually tends to be chronic in nature. And also now the causes of those lower GI bleedings are also varied. You can have your things like your you can have anorectal fissures, you can have hemorrhoids, you can have now those okay, any other bleeding that occurs past the fourth part of the duodenum, and it gives you that melena-like stool. But once you have your patients who come in with that, they usually tend to, their histories are they usually tend to be a prolonged history of having that tar-like stool. And like I said, they will present you those things like, now, these are the guys you'll find who have pallor. And when you do their hemograms, you'll find they probably have an iron deficiency anemia, what you call the anemia of chronic illness. So those are the kind of things that you'll get in terms of your presentation. But what differentiates that from upper GI bleed, like I said, most of the time that for upper GI bleed, your patients will just come and they'll complain of vomiting. Either they will vomit like bright red blood or they will vomit coffee ground vomiters. That's how you can differentiate between the two.
A great distinction. Thank you. And I think even in the algorithms, the part where it says do a DRE, that can also help you guide it. It's just a hemorrhoid or has it come through and through? Okay, the next question. For blood transfusion, in these upper GI patients who have anemia but are not actively bleeding, what is the best, packed red blood cells or whole blood?
Now, if your patient is not actively bleeding, remember, you're not just going to give them you're not going to transfuse unless your HB is 7 and below. So if HB 7 and below, you can transfuse them. Now, since you're not doing a massive transfusion and probably you're trying to get your HB back to a level of maybe around 10, you can actually do your packed red blood cells will actually be sufficient enough, because remember, you're not giving them quite a large volume of blood, so you don't need to do the platelets and the FFPs and all these things. So most of the time, you just find you can use either packed red cells or you can use whole blood. I think the two can actually work because you're not going to give them that many units. Probably about maybe 1 or 2 units of blood will be sufficient for them. And most times, once you are able to address the underlying cause of the bleeding, then the body, as usual, as it begins now to get back to its normal levels, once red blood cell production continues, their HB can actually go up because they're actually stable. But if they are bleeding, massive bleeding, then yeah, definitely pack red cells. Try to push that HB up as quickly as you can. Yeah.
Okay, great. Is there any specific recommended fluid for resuscitation?
Yes, the eternal debate between normal saline and Ringer's lactate.
Yeah.
Yeah. So, um, anyway, from the emergency point of view, like, okay, what I'd like to say is that between normal saline and Ringer's lactate, really not much of a difference has been seen. Okay, from the things that I've actually looked at, if you have normal saline, use it. If you have Ringer's lactate, use it. Because at the end of the day, you're not going to give such a large amount of it. You're just trying to stabilize your patient long enough for you to figure out how to stop the bleeding. And like we said, if the bleeding is too much, if they're losing blood, give them blood. 20 mils per kg, 20 mils per kg as an initial bolus of either Ringer's lactate or normal saline should actually be able to work. So I don't think there's really much of a big difference between the two. Yeah.
Absolutely. Remember, use what you have. Don't start debating. Use
Yeah.
what you have readily available. Okay. Another question. Does the use of xylate have a role in upper GI bleed management?
Silate in upper GI management. Maybe if you're looking at in terms of peptic PUD, could be. But if your patient is actually coming in with proper upper GI bleed, I will more likely just go for omeprazole if you're trying to stop the bleeding at that time, or you're just from the protocol of what the things that we have done. And then after that, when you're now looking at how you're going to manage your patient, then you're thinking, okay, if my patient actually has PUD, we do an endoscopy, if we find it is that, then you can actually put them on triple therapy or quadruple therapy. Yeah, but maybe.
Yeah. So yeah, remember to the way Dr. Mbuvi stratified his patients using the Glasgow scale. If it's a low risk patient, maybe the ones that you're discharging, maybe, but your high risk patients, you don't have time for xylate, and there's no proven benefit of that. Okay. Um, hmm. There's an interesting question here from Bernard Kenyatta. Does ice cold water orally have an effect on upper GI bleed?
That's a very interesting question because I'm thinking of it in terms of you're thinking about taking in ice cold water that tends to cause vasoconstriction, and then probably minimizing the amount of bleeding that will occur. I'm thinking that's the line around it. Honestly speaking, personally, not something I would do. I'm thinking about what are the other effects that ice cold water is going to do to this patient. Remember, your patient is losing blood. Theoretically speaking, the ice cold water, yes, tends to cause vasoconstriction. It may tend to stop some part of the bleeding. But remember, I think you need just to figure out what exactly, where is this bleeding coming from, first of all. That's because number one, like we were saying during the presentation, is that you need to understand where this bleeding is coming from. Then that will actually guide your management of this patient. So for that one, honestly, I've never seen it being done. I've never seen it being used. I don't know how well it will, but I'm thinking from a theoretical standpoint, it could work in terms of the vasoconstriction, but how how long will that effect actually last? Considering things like your core body temperature, and once this ice water gets into your stomach, it's probably going out to just now get to normal temperatures. Then you'll just have the rebleeding occurring again. So yeah, that's my take on that.
Okay, it's quite an interesting one. And on my side, I'm thinking this patient is, if they're vomiting, do you really want to give them anything orally again on top of that? And then I've just done a quick Google search on any published papers. I'm seeing there was an ice water lavage that used to be done in the 80s, but some recent papers have said that it has no role. Yeah, so maybe not.
Yeah. Okay, so I'm seeing there's one of the comments here by Romeo Homen. He's saying cold water in the Blakemore tube to inflate. Will make sense. But now, if we speak realistically, like I was asking, by the way, is there anyone who's ever seen a Blakemore tube or actually used one? Kindly in the chats, yeah, just let us know. We want to know what kind of. I know it kind of looks like inserting an NG tube. I think it will be the same, but yeah, maybe if you say the cold water in the Blakemore tube to use it for the inflation purposes, that would actually help do like a double effect thing. Yeah. But remember the issue about lavage, especially when you had that debate, especially with things like what is it called?
Maybe.
Poisoning. Yeah, when guys on poisoning, then you do gastric lavage to remove it. Now there is been the guys have just said, yeah, gastric lavage is not something to help with. Yeah.
Yeah.
Oh, I'm seeing someone who's saying yes. Apparently, they have. I don't know if the yes is for Faith Sheila. Faith Sheila. I don't know if you've seen the Black motive or you actually used it or both. That would be so awesome. Okay, that's cool. At least some people have seen it, which is nice.
It's interesting.
Yeah.
Yeah. Okay. Uh-huh. Mhm. Let me look for another one.
And you guys didn't read my last slide. Yeah. Yes, I have to.
It's a hot question. Hey, Joseph Moy asks, how much fluid can you give as you wait for blood?
Oh, yeah, that's now the other question. So we usually say you give your 20 mils per kg as a first bolus, and you can actually repeat that 20 mils per kg as your second bolus. Now, after that, if you don't have blood to transfuse your patient, I think you can still give another round of fluids. But remember, the more fluids you're giving, there's also the aspect of you hemodiluting your patient. You may be able to maybe help in terms of your getting your BPs to just to improve slightly. So that could be a thing. But what I'm saying is, if your patient is actually having like really massive hematemesis and they're actually vomiting up, sorry, not hematemesis, they're vomiting up a lot of blood. I think you, at that point, like I'm saying, the thing at the back of your mind should be, am I able to manage this patient with my current resources and in my current setup? So that if you're not able to, then you can actually initiate your fluid boluses as you're doing the two of them, and you've already called a facility where you can actually start transferring this patient to. Because I don't think, for me, what I've seen being done is that we usually give the two boluses, your 20 mils per kg first bolus, you give your second, but by the time we're doing the second bolus, we're already getting blood. I think I'm privileged enough that I work in a facility where we can actually get that blood when we need it. So now, if you're in a facility where you're not able to get blood and your only option is now just to keep giving fluids, you also need to consider that other aspect of your patient is losing blood, so you need to give them blood back. Because if you're giving them fluids, the fluid is not going to do the function of blood. So you basically might end up overloading your patient with IV fluids, and yet the main thing that they actually require is the fluid. Yeah.
Absolutely. Okay, good. Next question. Jacinta Wangeshi asks, can H. pylori cause upper GI bleed just by itself?
Yes, it can.
Yeah.
Yeah. So remember the pathophysiology of H. pylori, the way it produces ammonia, so it prevents it destroys the mucosal lining of the stomach or where it is. Now, as it destroys that mucosal lining, it means once those mucosal barriers have been eliminated, it means now the gastric acids are now able to actually, burn off the mucosa itself and actually be able to spread all the way in to actually get to the blood vessels and then also erode the surface of the blood vessels. And then now you get your bleeding. So yes, H. pylori through that particular mechanism of infection can actually lead to upper GI bleeding.
Okay. So Victor Onyino has a couple of comments regarding endoscopy. It's like he's not so confident about endoscopy during active bleeding. Probably the best idea. It's probably not the best idea in cases of Mallory waist tears and peptic ulcer disease. Is perforation risk more significant than benefit that you can possibly get?
Yeah, right, that's good. Yeah, that makes sense because doing an endoscopy when there's an active bleed might actually be tricky. How are you actually going to see? Because it's just going to be a lot of blood gushing. And actually, from some of I listened to a few of the podcasts in regards to upper GI bleeding in EM, and they were saying that sometimes they do get those situations where the patient is bleeding so much that even when the gastro come in and they put in the endoscopy tube, they're just like, yo, this bleeding is just too much. We can't even see where the source of this bleeding is. So they just remove the gastro tube, and then now they start thinking around, now is this a patient that now we need to start thinking about either one, interventional radiology, or number two, are we actually going to call in the surgeon so to just take this guy to theater, open him up, find where that bleeding is, and actually just deal with that bleeding directly. Those are some of the things. Yeah. So good points. Thanks for that. Yeah.
And I think even in your presentation, you mentioned that endoscopy can be delayed to 12 to 20. Yeah. So I think that, especially for the patients with active bleeding, for that exact reason. Then he also says, for patient with variceal bleeds, do they get propranolol? Yes, they do.
Yeah, I'm just trying to figure. Okay, yeah, yes, they do, but okay, I'm yet okay. Actually, that one I didn't check on the studies on that one for propranolol use for variceal bleeds. But that's something that I can actually go and look at. Hey, it's a good point, yeah. So it's actually used,
Yeah, it is. Okay. The next question. Martin Pritt, what would be the best approach when it comes to pre-hospital management of a patient with severe hematemesis with hypotension?
Okay, so I'll just repeat that. What will be that?
Best approach in the pre-hospital setup for a patient with severe hematemesis and hypotension.
Pre-hospital.
Yes.
Yeah, so I'm thinking that's probably coming off if you're called in to just evacuate a patient who has upper GI bleed and you notice that it's a lot. Like I said, do the initial management. Have this, put your large bore IV cannulas. Number one, so yeah, have your patient on a monitor, put your large bore IV cannulas, get your patient on oxygen, because I'll assume that the ambulance that you're using probably has oxygen. You have access to large bore IV cannulas, and you can actually start giving the first 20 mils per kg of IV fluids. Because remember, like the thing that we said, in other trauma cases, it's very easy for you to do pressure dressing, or applying pressure to a bleeding external. But now this patient is actually bleeding internally. There's really nothing much you can do at that point, except do the main things that you can. One, like I've said, put your patient on oxygen, get 2 large bore IV cannulas, do your 20 mils per kg. And by this time, you actually now getting your patient into the ambulance and rushing them to a facility where they can actually be assisted. Where now all these other things can be done. Your intubations, if need be, to secure the airway and getting the gastro involved and all these other things. So in terms of pre-hospital care, I think the main things that you can do is look at your airway, breathing, circulation. What of these three things can I actually impact? In the field, you may not be able to intubate your patient. So maybe you might be thinking now in terms of, let me just get these 2 large bore IV cannulas in. Let me start my IV fluids. Let me put this patient on oxygen. Let's put them on a monitor, get the vitals, call the hospital and tell them, we have this patient, this is the situation, and we're on our way to you.
Yeah, absolutely. Everybody has their role, so do what you can with your available tools and hand over. Okay. So Thomas Machuma asks, do you warm the fluids or do you give them as they are?
We usually give them as they are. Hopefully they are at room temperature. So you just give. If you're in a facility where you can get warmers, will work. I'm thinking in terms of their hypovolemia, and also thinking about around the patients in terms of their temperatures, their, what is it called? Whether they're hypothermic, hyperthermic, all those things come into play, especially in the emergency department. Most of the times, we usually just give our fluids. We give our fluids just at room temperature, because sometimes getting access to a place where you can actually warm the fluids, if you can, would be a good thing to do. For now, for us, not really. I don't think so. I've not personally not done that, not done anything with warm fluids. I've just been giving just the normal room temperature, and we just give. Yeah.
Okay, yep, that's true. So just a few more comments on the propranolol, just to reiterate, it's not an acute drug. It's usually given later on for further management. Elizabeth Kariuki has also commented, it's avoided in the acute settings because you could already be hypotensive. Yeah, so it's not used in the acute if they're acutely bleeding, but later on for prevention of rebleeds in your varices that are from portal hypertension and whatnot. Thank you for that. Now,
I can see one Jacqueline Chepkemoi is saying maybe blood. I think she's talking about warming blood when you're giving blood. But even then, even in our setup, the blood is usually it's in the refrigerator. So when we get the blood, we usually just give it as it is. Yes, I know you're thinking about the concept of now this patient being hypothermic. But now also the question comes in, how warming the blood, because remember, if you're giving this blood and you're giving it in the emergency setup, you're actually doing it because your patient is actually really bleeding out and you need to give this blood as soon as possible. How long will it take to warm that blood? Maybe that's my take. Maybe up for correction and everything, but yeah.
I think also we need to consider that there are active elements, red blood cells and whatnot, that are very sensitive to temperature. So you don't actually, I don't think we ever warm blood ever. Fluids I've only seen it being done with hypothermic patients where you can actually stick the fluid bag in the microwave and then warm it. But in these patients in our setup, there's really not much role for that. Yeah, because it's more of a volume issue, not a temperature issue.
Yeah.
Okay. So I'm just trying to filter some of these questions because some of them are going past the scope of the conversation. So let's talk about this tranexamic story. Yeah.
Yeah.
I'm sure a lot of people have been using it. Anyone bleeding gets tranexamic stat, right?
Yeah.
And yes, there have been very many controversial and even contradictory papers that have been done. You did mention the systematic review that was done in 2020, right?
Yeah.
Yeah. Then, funny enough, a year later, there was another one that I think is by most people is taken as fact, which review meta-analysis that was looking at three outcomes: reduction in bleeding after giving IV tranexamic, likelihood of rebleed, and adverse effects, which adverse effects was qualified as venous thromboembolic phenomena and PEs and things like that. So for meta-analysis, they actually showed that extended high dose, basically what we usually give, the start dose and continue it, had a negative effect. They had higher adverse effects on the patient. So those patients are more likely to get PEs and DVTs as opposed to the ones who got the placebos. And this was done, it was quite like 17 RCTs were included. That was quite interesting because, again, we tend to give tranexamic quite often because we think it will help slow down the bleeding, but we never really think about what it does outside of the area of bleeding. So I think that's what that meta-analysis was looking at. So there was no reduction in mortality. There was no added benefit in terms of reducing or reducing risk of rebleeding. And in fact, there was higher chances of getting a PE. So for our upper GI patients, there's really no role for tranexamic. So we should really stop giving it. Even in the ambulance, don't give tranexamic until maybe next year. There'll be a new one.
A new study.
A new study that says, yeah, give. But as of right now, the risk of getting a PE versus a hopeful reduction in bleeding, it's not worth it. Okay.
Yeah, that's true. Yeah. I think the other thing I had maybe not mentioned was now in terms of when you're doing your RSI, your rapid sequence intubation, we usually have this tendency where we pre-oxygenate the patient using the BVM. Yeah. So for one of the things I was reading, when they were saying that when you're doing your bagging, you need to be careful. And sometimes they can say that you can do, you can put in a nasal catheter with just the direct flow oxygen. and then intubate your patient. Because remember, when you're doing your BVM, there are many times when that air that you're pumping actually goes into the stomach. Now, if this patient is having like massive bleeding, that pressure that you're building up in the stomach can actually increases the risk of your patient aspirating, because all that blood is actually now just pushed up into the esophagus and now can actually go to the trachea by the time you've actually intubated your patient. So there was that aspect of it, because I've seen someone asking a question in regards to SpO2 when you're doing your intubation. Like what I was saying, once you have once you're bugging your patient, I think once your SpO2s are in the 90s and above, and remember your RSI, the reason why it's called a rapid sequence intubation, then you actually have to do it quite rapidly. And like I've said, one of the things that you will need to do when you're intubating is to ensure that you have a clear field of vision. So one of the techniques that I read about, and I think I've used it once when intubating a patient and actually figured that it works, is that on the laryngoscope, the way the blade is designed, there's a space where, like there's an edge on the laryngoscope. So there was a technique where you actually take the suction catheter of your suction machine and just hold it there in that groove of the laryngoscope. And then as you're going in, it's doing continuous suctioning as you're looking to find your vocal cords. So it provides like continuous suctioning. Or the other one will be have someone on the side of the patient. They usually say you hold the patient like the mouth of the patient like it's a hook of a fish, like that, and pull a bit to the side, and then stick the suction tube inside there, so that it continues providing that continuous suctioning as the person who's intubating now can be able now to visualize the vocal cords and quickly intubate the patient using as minimal time as possible. Yeah.
Awesome, thank you. We'll do a few more of these. Is there any use or role for use of Voluven as a fluid expander instead of Ringer's lactate?
Okay. I think now, okay, the few things I've seen, when when you're using your volume expanders, I think I'll just stick to my part of just saying blood is the best. It can maybe, yeah, blood is the best. I don't know, I'm trying to remember clearly whether I think I read somewhere about volume expanders in regards of them not being utilized and being phased off in a way. Yeah. So
studies shown that they do more harm than good. They actually have a higher profile than not using it. So your patient, if you give a volume expander, your patient is more likely to die because of the volume expander, as opposed to if you just gave them fluid and blood. So not. In fact, they should just be ni kama cough syrup.
Oh yeah. Yeah, that's the thing. Yeah, because I was trying to remember, because I think somehow I remember reading something in that regard about volume expanders and not being utilized in emergency departments because of that particular aspect. They actually tend to increase mortality. So if you have blood, give blood. If not, give your crystalloids, and just like I'm saying, like, and I'll keep reiterating, be prepared to refer your patient. Have that on the back of your mind. Know your limitations. Know how far you can get with this patient. Be planning for your patient's referral as soon as the patient has stabilized.
Absolutely, thank you. This one is an interesting one. What Benter asks, what management do you give to a patient who develops upper GI bleed upon initiation of anti-TB medication?
Okay, upon initiation of anti-TB medication. So now, like I say, it will depend on the bleed that the patient has. One, if it's massive bleeding, we are doing the same things that we have talked about here, because that's an emergency. That's what you're dealing with in the emergency department. If they develop upper GI bleedings, which is now like minimal, and these are patients you can manage as an outpatient setting, then now you need to start thinking about what medication, which of these anti-TBs is actually the one which is causing, if at all it is the anti-TBs, which one of them particularly is causing the upper GI bleed. And then there will also be the aspect of, if let's say you identify the particular drug that is causing, okay, let's say you find, let's just give an example, like you find it's rifampicin. Are you going to stop it? Yeah, because you're treating TB, because this TB will actually kill the patient. If the bleeding is minimal, you can try and figure out if it's been caused by ulceration, the mucosal damage. Then now you can start thinking about doing your PPIs. You can now consider sending them to a gastro so that they can just have a scope done, figure out where this blood is coming from. But in the aspect that they're actually undertaking anti-TB medications, and we know the burden of TB in this in sub-Saharan Africa, and we know that missing of medications in terms of anti-TBs, you have to do a risk versus benefit analysis for that particular patient.
There's a question about whether to use carvedilol or propranolol for a variceal bleed. I'll just take that one for you. So both are non-selective and they're non-selective beta blockers, and they're usually the drug class that we use for variceal bleeds. So
Yeah.
you can use either. Both show benefit, so use whatever is available to you. Propranolol tends to be very cheap, so you can just give your patient that and it works. So yeah. And then also just to have one more comment on that patient who had TB and an upper GI bleed.
Mhm.
Honestly, if your patient has a massive GI bleed, that's what's gonna kill them first. So all you really need to do is to PPI yourself, personal protective PPE, PPI, personal equipment.
Yeah.
Make sure you have an N95. Yeah, everybody around you has an N95 grade mask, and intubate as needed. Yeah, so just because they have a communicable disease doesn't mean that they don't need emergent care. So it's the same thing, like the same quagmire we had with COVID patients, right? Do we go in and resuscitate, intubate COVID
Yeah.
patients? What am I going to get COVID? It's a similar
Yeah.
discussion.
Yeah.
Okay. Uh,
And maybe I can take one here because I'm seeing Dennis Meriti is asking about something I had mentioned about the posterior nasal bleed. And yes, it's true. They can actually present as upper GI bleeding. Like I was saying, if the posterior nasal bleed is significant, most of the time they tend to swallow the blood. And then if they vomit up the blood, it will actually look like it's coffee ground vomiting. So how do you differentiate is that if most of the time you'll find your upper GI bleeding tends to be, if it's massive, like I said, your patient will come in, you will be thinking it's upper GI bleeding. You will do your initial assessment of this patient and then just follow the protocol of how you're going to manage them as you're trying to figure out where exactly this bleed is coming from. So the possible differentials will be posterior nasal bleeds. Also, patients sometimes can present with hemoptysis, but how you will differentiate between hemoptysis and upper GI bleed is that if your patient is actually coughing up that much blood, your patient will probably be dying because the lungs can only hold so much blood, and actually they'll be feeling like they're drowning within there, or they're actually having pulmonary edema at that particular point in time. So yes, posterior nasal bleeds can mimic. I'll say they'll mimic upper GI bleed because of the fact that they will actually swallow the blood and then maybe they can vomit it up. Now from that, they just need you to just do your very clear clinical assessment. Look at the risk factors for this patient. Do they have any risk factors for upper GI bleeding? Consider sending them for an endoscopy, and also have these complications at the back of your mind that you may need to send this patient either for a chest X-ray if you're thinking there could be something else in the lungs, doing a postnasal space X-ray as well, looking whether doing a rhinoscopy to see whether there's any bleeding for a posterior nasal bleed. I think those are some of the things that you can do to just handle that.
Great. And then the next question is about the role of prokinetics in upper GI. I think the most important ones that we can really talk about is erythromycin and metoclopramide. A lot of gastroenterologists prefer to give a start dose of erythromycin prior to endoscopy. There are a couple of RCTs and large RCTs and meta-analysis that show that that start dose of erythromycin helps prevent need for a second endoscopy thereafter, or a relook endoscopy. Metoclopramide or Placil as an antiemetic is actually considered the best first choice for your patient, because there are some studies that have said that it reduces your rebleed risk, which neither here nor there, but yeah, so you can use Placil, you can use metoclopramide. Those are the prokinetics of choice. Yes. How do you manage children with upper GI bleed?
I'll go with the same concept. If they're having upper GI bleed, you need to just initial management, I think actually remains the same. Remember, if they come in as an emergency, it's still the same things. Your airway, your breathing, your circulation. Sort those ones out first. As you're figuring out, number one, why is this child having an upper GI bleed? Considering that upper GI bleedings have been seen to be more in the older generation, guys who are 40s and above, sometimes it can occur in people earlier, especially for people who have been using NSAIDs for long over-the-counter prescriptions of NSAIDs, they can actually present with upper GI bleeding. But now, if a child presents with upper GI bleeding, then now you really need to ask a lot of questions. Because what could it be? One of the things I'll think about, maybe it could be those arteriovenous malformations. But I think that's one thing that comes to mind. But still, same plan of management. I will go with the same plan of management. Maybe the doses will have to be reduced based on just the pediatric dosing, but also getting in your pediatric gastroenterologist in on the case as early as possible. Those are the things I can say. I'm yet to see a child who was presented with upper GI bleeding, but that's a very good question. It's a very good point to look at, because yeah, we do manage both pediatric and adult cases in the ED. It would be nice to know that.
True. Okay. I'll do the last 3 questions and then we can do a nice little summary. Okay. In case of an upper GI bleed that is highly suspected to be variceal, is NG tube insertion more risky?
Okay, so variceal bleeds, like we said, they tend to bleed a lot. And the reason why, okay, so when you're trying to put in your NG tube, at that point, you're putting in your NG tube on your patient who's intubated. That was one of the things I found from the research I was doing for this particular topic, is that the recommendation is that if your patient is having such massive bleeding, so you need to secure their airway, and then at that point now you can pass in your NG tube. Now with variceal bleeds, I didn't find any contraindications to NG tube placement for variceal bleeds, unless Jean you found something. But from what I went through, I didn't find any. And from the actual things that I went through, they said that having the NG tube in situ can actually help you in terms of knowing how bad this bleed is ongoing. Because now, if you imagine that you've done everything for this patient, you have fixed your large bore cannulas, you've given your fast fluid boluses, you're sourcing for blood, you've given your omeprazole, you've given your PPIs, an antibiotic, and all these things, and then you had to secure the patient's airway because they actually have a quite massive vomiting up of blood. And then now you pass an NG tube, and then the NG tube, since it's connected to a bag, then now you notice that actually that blood is still coming out. So despite all your interventions, your patient is still, still bleeding. So it can actually help you in terms of knowing if the bleeding is actually ongoing in that patient. And then now that's the point now you can start thinking if you don't have a gastro, but you can have access to a Blakemore tube, you can put it in. Or now you can start thinking about calling in your hepatobiliary gastro surgeons to come in and figure out what they're going to do for this patient. But I didn't find any contraindications in terms of my research in regards to NG tube placement, except on the point where they were saying it's usually very, very, like we all know, it's very, very uncomfortable passing an NG tube in a person who's awake. So that was the only thing that they were saying we need to be careful about. But they were saying in a patient who's already intubated, because they're sedated, you can actually just pass your NG tube quite easily. Yeah.
Okay, good. Okay. A couple of people are asking about PPIs. Yes, PPIs are the mainstay of treatment in terms of which one to choose based on what other medication your patient is on. So omeprazole, pantoprazole are the best ones. Then there's a question about delaying transfusion. Do not delay transfusion if a patient needs transfusion. Give it to them as soon as possible. And then there's a question about if you don't have blood immediately and your patient's HB is less than 8, can you give FFP in the interim?
That's interesting. Okay, first of all, I'm actually wondering, you'll have FFPs but not blood. That is
Exactly. So
yeah, I'm actually thinking, wow, you actually have FFPs but you don't have just blood. Um, honestly speaking, I'm not so sure about that. Maybe you're looking at FFPs in terms of dealing with the coagulation effect, but remember, your patient is losing blood volume. And FFPs, they will not be enough to bring back that blood volume that your patient is losing. So you need to replace the actual blood that this patient is losing. So my preference would be, if you can get blood, get blood. FFPs will not really help you, especially unless now you're doing a massive transfusion protocol. So that's where now the FFPs will come in. But if your patient is just bleeding, the best thing to do is just give them blood. Yeah.
okay. Yep. Okay. Thank you so much. That has been very, very, very informative. I think you guys have learned a lot. Maybe just to reiterate for everybody, the algorithms are there to help you. A lot of the questions that we've gotten today are just have a recheck at the algorithm. You'll be able to see the emergency steps that we need to do. Things about discharge, leave to the gastroenterologist. So download the Casualty app. If it's on Play Store, Google Play Store, and the App Store, and you'll be able to keep up to date even with like the changes, especially like
Yeah.
this controversial tranexamic story. Yeah, we tend to update the app faster than disseminating
Then the
physical.
algorithm, yeah.
Yeah, yeah. So yeah, always resuscitate your patients. Yeah, think of what is gonna kill them first. Handle that first, and then the other things will follow. Any parting shots, Dr. Mbuvi?
Just to say thank you so much for this opportunity to give this presentation. It's been awesome. I saw at some point we had like 500 participants. I was like, wow, whew, hao ni watu wengi, but yeah, it's been awesome. But I've also learned. That's the joy I have about this EM talks, that the present and also you get to learn. It's an exchange of information. So I've actually learned a lot in things that I can go and look at. It's been a pleasure. So thank you so much, guys, and I wish you a lovely night.